of medical oncology, sees lots of patients, and he built up what is called CTOP. CTOP is the equivalent of something which was founded by Rolf Stahel, ETOP, European Thoracic Oncology Platform, the Chinese Thoracic Oncology Platform, and they run multiple studies. And I welcome you to give the first talk. It's on medicines run in China.
No. Yeah. Okay. Good morning, dear colleague. First of all, I would like to thank Professor Weder and Professor Stahel to give me the opportunity to introduce the lung cancer clinical trials in China. It's really my pleasure to be here. Actually, previous 12 years, we get a lot of help from Switzerland colleagues, especially Professor Weder. You train a lot of the young fellow for us. So just thanks to all of you. Actually, the incidence of lung cancer in China is higher than that in other countries, especially because of the smoking, air pollution, and the age of the population. And last year, the first China government published the national so-called cancer statistics in China. Actually, quite similar like the previous speaker say that lung cancer incidence rate in male in China actually the #1 killer for all of the cancer. And also the lung cancer incidence for female ranked at #2. But in terms of modality, no matter male and female, actually lung cancer is the #1 cancer killer in all of the cancers. So it's really a big problem for us as well as for other part of the world. And since last decade, actually guided by the GCP, cancer drug developed in China so quickly. You can see here, compared with 10 years ago, actually a lot of clinical trials now launched. Nearly every year, nearly more than 280 clinical trials. And now you can see here a lot of early phase study and also the IIT study or IST study is already launched. You can see here the clinical trial training in China get the number has dramatically increased and reached the peak in 2013, especially the small molecular trials. You know that in Asia population, a lot of like the EGFR mutant. So a lot of the clinical trial with the EGFR mutation patient, especially the small molecule like the gefitinib, alatinib, and afatinib, also the Chinese domestic product acaltinib. A lot of study about this. So nearly in China, nearly more than 80 trials. But China is a so big country and the developed unbalanced. So usually the clinical trials in big city, like the Beijing, Shanghai, and Guangzhou. So totally last year, lung cancer trials, 490 clinical trials registered in clinicaltrial.com. And the paper for JTO, the state of lung cancer research, a global analysis. In this paper, actually shows that China, in particular, exhibit a marked rise in the value of research at the over of the last decade. So we have dramatic change for Chinese research within these 10 years. And that historically, usually the majority of patient is non-small cell lung cancer. Previously, like the squamous, we get the studies, actually the 30 years ago, more than 50 patients actually squamous, but now squamous only around 25%. The adenocarcinoma increased dramatically. You can see here, actually the national data show that the adenocarcinoma more than 70%. But even in Shanghai last year, adenocarcinoma is more than 80%, in non-small cell lung cancer. So it's a dramatic increase. We don't know why, but because of a lot of the female GGO, they have the adenocarcinoma with the EGFR mutant. So actually, we do some study, especially this study is this for surgery. We already explored the intraoperative frozen tissue section diagnosis for AH, for ISC, for MI, or invasive adenocarcinoma. We can see here that actually the frozen section is quite good to predict, compare with the PPF tissues. So now, actually, we know that for the surgery, you selected lumpectomy or sublumpectomy, usually based on anatomy. Now the precision medicine time. So can we, from the anatomy, move the pathology diagnosis, guide the surgery? So actually Japan, previous 2 studies already explored the relationship between imaging with the pathology and the imaging with surgery. Now Chinese study shows the pathologists with the surgery. So we already discussed about the study based on the frozen tissue. Then the surgeon do the selected type, lumpectomy or sublumpectomy, or you just do the visual resection, not need any, the median standard lymph node in very early stage, but based on the frozen tissues. And in terms of staging, actually, China is still a developing country. So a lot of patients actually, when diagnosis, around 60 patients is already stage 4. Compared with the United States, we have so many late stage patients. And in my institution, actually, our database contribute for the IOC lung cancer staging project. So I just mentioned that our database has already, connected with the IOC staging project. And also, that in terms of the later stage, I'm a medical oncologist. So within these, 30 years, we from the chemotherapy to targeted therapy, then quickly move to the immunotherapy. So how about the chemotherapy? Actually, we ask the question that, is that can tolerate the same dose with the Asian population versus Caucasian population? You know that usually we do the global study where everything talk about the taxol, no matter docetaxel or taxol. Japan always say that we just can tolerate low dose. So we do the study in China. Compare with the docetaxel standard, global doses, 75 milligram per meter square versus Japanese, recommended data, 60 milligrams. And then we presented in ASCO at the 2030, actually this is the oral presentation in ASCO. We found that actually 60 milligram in Asia population can tolerate well and actually get the same efficacy with the so-called global standard. So now in Asia, we will recommend 60 milligram. So we found that different populations actually even tolerate the chemotherapy, the dose is maybe different. But we also found that for the Pemetrexed, maybe Asian population can tolerate a high dose. In Taiwan and also in China, we do the study. But the effect is the same, so we still use 5 milligrams per meter square. So now move to the biology. Within these 20 years, actually from the, the EGF expression to the mutation, we from the pathology to the molecular pathology, now to the panel, next general sequencing, and also for the immunotherapy diagnosis. What's about the East Asia? We know that in adenocarcinoma in East Asia, in China and Japan, it's the same. Usually EGF mutant patient, more than 50% of patients. Compared with the Caucasian population, you have already maybe 10 to 15%. So it's a molecular profile may be different in adenocarcinoma, also as well as in squamous, a little bit different. So we have so many EGFR mutant patients, so a lot of actually EGFR TKI the clinical studies include the Asia study. It's only one study I know that in Europe, this is the UTAC study. Other studies, the majority of patients actually come from the Asia. The IPA study, the majority of patients from China and from as well as Japan. Optimal study, a totally Asia study. Luxon 6 is totally Asia study. The patient mainly from China. This is the Chinese registration studies. And also we have the domestic product for the first generation TKI, like we call it acotini. We already present two, the studies. One is the second line, published in Lancet Oncology. Another study is the first COVID study is already presented data in ASCO. So we also explored the EGFR mutant abundance. We found that maybe the high abundance, you very sensitive to the TKI, but some patients although have the mutation, but a low abundance, maybe they have the short progression-free survival. And we also explored the Chinese so-called third generation TKI. We presented data in this year in ESMO meeting. This is what we call the AC0010. This is a compound quite similar like the AZD9291. We presented the phase 1 data. This is the dose escalation data. And show that the overall response rate are around more than 50%, especially in BID dose regimen. So now the phase 3 study is already ongoing. Hopefully it will be approved next year. And also we try to more active to involve the global study. And here I just present one study is a pre-planned subgroup analysis for LUXN 8. Actually, I'm the PI of Asia, the whole Asia area. And we present the data. Showed quite similar, the results with the whole group. And in terms of the ALK inhibitor, actually, we participated since 001 to 007. This is the global study. But we also do the Chinese study or the Asia study. This is profile 1029. I present ASCO in last year. In all positive patient, chemo-naive, clonotinib versus standard chemotherapy. We found quite good results in ASCO. And this is quite similar like the 1014 published in New England Journal of Medicine. And we already submitted the data to the JCO. And in terms of roles, it's the same. The Dr. Wu presented data in ASCO in last year ASCO. This is the Asia study, but China contribute the majority patient. And I should say that within 1 year, my institution actually screened the ROS1 15 patients just within 1 year. The ROS1 around 1 to 2% patients. So we have so many patients to screen, contribute for this study. Actually, the study shows that in China patients quite similar like the whole group. You can see here the whole group, 127 patients in China, 74 patients. So majority of patients actually come from China. And also for the CMET, INC280, this is the CMET inhibition, and the drug developed in China since phase 1B to phase 2 study. You can see here, this is the preliminary effects data. Show that 8 patients responded, 7 patients responded TKI as their last protocol treatment. Totally 17 patients. But a percent of patients get a response. We do the subgroup analysis, show that if the patient with higher MET positive immunohistory actually get quite good results. So actually the randomized phase 3 study is already launching in China. So in terms of the liquid biopsy, actually China already published a paper in 2012. At that time, we do the plasma DNA samples as an EGFR mutant to predict the tumor response. And compare with previous, just compare with tissue versus serum or versus ctDNA. Now we also do the study based on the serum. Actually, we already do it's quite the same. We do the next-gen sequencing based on ctDNA, then we do like the cluster study. If the mutation, EGFR mutant, you just get first generation ALK, you get the clonotinib. The study is already ongoing. We have already 32 patients in this study. And also in terms of umbrella study, this is the cross study already, still ongoing. And this is the first umbrella study actually in Asia area. Hopefully it will be helpful for China, the early drug develop. And in terms of the anti-antigen genesis, actually we already know the ECO 4599 and AVAIL study in Europe, but still China need a registration trials. So we do the quite similar study, carbo plus paclitaxel plus or minus bevacizumab, and we presented published a paper in JCO, got quite good results in terms of progression-free survival and also the overall survival. So actually, the Beyond study is confirmed the previous the Europe study and also as well as the United States study. But you know, this study actually allowed the patient the EGFR mutant. It's not like the European study and like the United States study. And also in this year, in this year Weder conference, I presented a small molecule, but this is a high selective VEGFR oral pill. We call it for continuity. We just beyond the third line, beyond the second line chemotherapy for continuity versus placebo. You know, we get quite good results. I present the data in the Weder conference. Actually, we meet the primary endpoint. The no matter investigator evaluation and the independent review committee show that for continuity improve of the progression-free survival. And also do the subgroup analysis show that maybe benefit even in EGFR mutant patients. So now the randomized phase 3 study is ongoing to confirm the survival benefit. Total is already more than 280 patients in this study. We want more than 500. But we hopefully we will finish the study, patient enrollment at the end of this year. And we will present the data next year. So I mean that for this small molecular VEGFR shows some activity and also show that we can do some studies in beyond the second line chemotherapy, actually no standard of care. In terms of the immunotherapy, within these 2 years, no matter in EMA or FDA, are already approved the nivolumab, pembrolizumab, and also atezolizumab. In China, the study is for nivolumab. It's already patient enrollment is finished. We just follow up. We wait to the results. Hopefully, at the end of this year, the drug will be approved in China. And in terms of the atezolizumab, the study is ongoing. I'm the PI of the Asia of this study. This is the regional study. Atezolizumab versus docetaxel. The patient enrollment more than 300 patients. So we hopefully this year the patient enrollment will finish. And also in terms of the pembrolizumab, the frontline study is already ongoing in China. So actually, the last I should mention about the CTOP, as Professor Weder mentioned. Actually, we learned from our European colleagues, especially Dr. Stachel from the ETOP. Hopefully, we want to establish in China Chinese thoracic oncology platform. But we want this database through the so-called mobile healthy technology. Now mobile phone very common actually in China, no matter patient or doctors. So the mobile health is widely used in not only in oncology but also other area. So this is what the CTOP follow-up system. We follow up the patient with the psychology, with the diet, and with the quality of life. And the patient will answer the questions using the mobile phone. Something China, the app like the WhatsApp, we call the WeChat. We're using the WeChat every 3 months to follow up the patient, and the patient on the website answer some questions, and we get some data. So and also explore the PM 2.5. This air pollution is a big problem in China, so hopefully we want to explore the personal exposure of this kind of the data. And also we know that for the CTOP, we want to meet 4 V's, that volume, big volume, the velocity, high velocity, and variety and veracity. And as Professor Weder showed the picture, we have since at the end, update for last month, we're already more than 1,000 physicians involved CTOP, and the patient number is more than 40,000 patients. So thank you very much.